Hello guys, hope everyone is really good. Okay, guys, this is part 2 of our rapid revision program. I hope everyone liked the part 1 of the rapid revision. Now, in this part 2 of the rapid revision, we'll be covering all the leftover topics. Like in the first part, we haven't done with the renal and also we haven't done with the endocrine as well as the general. So, in this part 2, let's try to complete all these topics, whatever we are leftover, whatever we have leftover last time, we'll just complete them. And I know this is a very crucial time for you. Each and every minute of yours is such an important thing. I will try to complete the most important points and in a very fast way. Having said that, without any further ado, let's start our system, that's the endocrine physiology. Okay, endocrine physiology. Now in the endocrine physiology, the first important topic is the pituitary gland. Every student knows there is anterior pituitary as well as a posterior pituitary. Now here the important points which I want you to know is, see, in the anterior pituitary, this is the anterior pituitary. In the anterior pituitary, there are 5 different types of cells like somatotropes, corticotropes, gonadotropes, thyrotropes, lactotropes. Important point is, out of all these cells, which cells are acidophilic cells? Okay, if I take the pituitary gland and if I stain the anterior pituitary gland, the cells in the anterior pituitary gland are going to take up the stain, like the eosin stain as well as the hematoxylin stain. Certain cells will take red color, the acidophilic cells. So which of the following are the acidophilic cells? That's the important MCQ. The acidophilic cells are the somatotropes and as well as the lactotropes. Somatotropes produce which hormones? Somatotropes produce growth hormone. Somatotropes produce, the somatotropes produce growth hormone and lactotropes produce prolactin. Okay, prolactin. So these two cells of anterior pituitary are acidophilic cells. They take eosinophilic stain. Okay. Now inhibitory control by the hypothalamus. We all know on the top there is hypothalamus. Hypothalamus is the master regulator for the endocrine system. So hypothalamus controls the pituitary gland. Hypothalamus controls the pituitary gland. Hypothalamus, it shows inhibitory control on which of the following hormones? Okay, inhibitory control by hypothalamus is shown on 2 important hormones. One is growth hormone. If you ask me how, hypothalamus produce growth hormone, inhibitory hormone. That growth hormone, inhibitory hormone inhibits the growth hormone from the somatotropes. Okay, so growth hormone is getting inhibited from the hypothalamus. Yes, it's a true statement. As well as prolactin. Okay, from the hypothalamus, dopamine is being released. See, very important point. From the hypothalamus, who is being released? Dopamine. Okay, so dopamine from the hypothalamus, it will inhibit the release of prolactin. So who are under inhibitory control? Again repeat, growth hormone as well as prolactin. Prolactin is being inhibited by dopamine. So dopamine is called as prolactin inhibitory hormone. Okay, now after this, the important clinical scenario which I want you to know is, see, whenever there is a pituitary stalk damage, see, here is the hypothalamus. The topmost part which I am showing, the topmost thing is the hypothalamus. Hypothalamus is in contact with the pituitary gland. Now here what I am showing is, there is damage at the level of pituitary stalk. Hypothalamus got detached from the pituitary gland. Now what happens? Again think logically. Hypothalamus normally controls the function of pituitary gland. Hypothalamus controls the function of pituitary gland. Whenever there is a dissection, whenever there is a transection between hypothalamus and pituitary gland, do you think pituitary gland will work? No. So what happened to all the hormone levels? Sir, all the hormones are going to come down. ACTH, adrenocorticotropic hormone from the anterior pituitary goes down. Growth hormone goes down. Thyroid stimulating hormone goes down. FSH goes down. Luteinizing hormone goes down. Everything is coming down. All hormone levels are getting decreased. But prolactin level increases. Very important point. The prolactin level increases. Why? Why? Because normally hypothalamus inhibits the prolactin release. Hypothalamus, by producing dopamine, inhibits the prolactin release. But whenever there is a transection here, whenever there is a damage at this area, dopamine is not coming down to the anterior pituitary. Dopamine is not coming down to the anterior pituitary. So dopamine no longer can inhibit the lactotropes. So now prolactin levels are going to be increased, but all other hormone levels are going to be decreased. Okay. Now after this, The next important condition which I want you to know, the next clinical condition, it's a very simple thing, is the Shihan syndrome. Now, what exactly is this Shihan syndrome, sir, if you ask me? The Shihan syndrome is postpartum. The definition is very important. Please concentrate on my definition. Postpartum necrosis of pituitary gland. Okay, it's a postpartum necrosis of the pituitary gland. What exactly I mean by is, whenever or simply try to understand like this. Now there was this one female who have undergone, like, the delivery, the process of the delivery. Now during this delivery there is a lot of hemorrhage. Okay, there is a lots and lots of hemorrhage. Now she lost almost 1.5 liters of blood. Think like this. Normally, usually in a normal vaginal delivery, there will be 500 ml blood loss. In cesarean section, there will be 1000 ml blood loss. But if she is having too much amount of hemorrhage, that is called as postpartum hemorrhage. Postpartum hemorrhage. Now, whenever there is so much amount of hemorrhage is happening, what happens to her blood vessels in her body? All the blood vessels in her body are going to undergo vasoconstriction. The blood vessels in her body, to maintain the blood pressure, all the blood vessels will undergo vasoconstriction. Whenever there is a vasoconstriction, what happened to the blood flow to the pituitary gland? The blood flow to the pituitary gland is going to be compromised. So whenever blood flow to the pituitary gland compromises, that causes a necrosis of the pituitary gland. Okay, see, this Shihan syndrome is not going to happen in each and every female. It's not going to happen. So those females who have severe amount of hemorrhage, those females can suffer with this Shihan syndrome. So after postpartum hemorrhage, if the pituitary gland is necrosed, means that is called as Shihan's syndrome. Now in Shihan syndrome, what happens? All the hormone levels goes down. Growth hormone level goes down, thyroid stimulating hormone goes down, follicle stimulating hormone, luteinizing hormone, ACTH, prolactin, every hormone is going down because the entire pituitary gland is gone. Pituitary gland is gone. Okay, so this is what you should know regarding the Shihan syndrome. Okay, Shihan syndrome. The definition is important. Postpartum necrosis of pituitary gland is called as Shihan's syndrome. Okay. Now, guys, let's discuss about the growth hormone. Okay, growth hormone. First of all, growth hormone is an example of anabolic hormone and catabolic hormone. Growth hormone is an example of anabolic hormone. Okay, if you have any doubts, you please put it in the chat box. Okay, I will reply to all your questions. So growth hormone is an example of which hormone, guys? Anabolic hormone. It's not a catabolic hormone. Now, what are the functions of growth hormone? Now, growth hormone have what kind of functions? On adipose tissue, lipolysis, guys. On adipose tissue, sorry, lipolysis. All the fats in the body are going to be broken down. All the extra fats which are present in the body will be broken down. It will make growth hormone. If you have good amount of growth hormone, it will make your body in a good shape. So lipolysis. Now, what about the muscles? I have already said you, growth hormone is an anabolic hormone. It will make your body into a good shape, which means it increases your muscle mass. Okay, so there is proteogenesis. Okay, lipolysis, proteogenesis, and what happens? If growth hormone is acting on the bones, bone growth. Okay, growth will happen. Okay, growth of bones as well as the viscera. Growth of bones as well as the viscera. Now, on liver, if growth hormone is acting on liver, what happens? Very important point. If growth hormone is acting on liver, by the process of glycogenolysis, blood glucose levels will be elevated. The blood glucose levels will be elevated. Don't forget, very, very important point. And also remember, growth hormone, when it's acting on the liver is going to produce something called as some substances like insulin, like growth factor or somatomedians. So, insulin like growth factor or somatomedians are nothing but growth hormones. Okay, whenever growth hormone is acting on the liver, in the liver they will be converted into insulin like growth factor or somatomedians, and these also help in the growth of the body. Okay, one important point, growth hormone increases the blood glucose levels. So from this, can I say growth hormone is a diabetogenic hormone? Yes, it's a diabetogenic hormone. It's a diabetogenic hormone. Why? Because it increases the blood levels of glucose. Okay, if there is too much amount of growth hormone, that causes too much amount of blood sugar levels, which will cause diabetes. Okay, it's a, sorry, it's here, right? So it's an example of diabetogenic hormone. Now, growth hormone, if because of some reason like a pituitary adenoma, if a child is having excessive amount of growth hormone, means it will cause what? In child, it causes gigantism. So gigantism is because of the excessive amount of growth hormone during childhood. Now, if there is excessive amount of growth hormone in adults, okay, if there is excessive amount of growth hormone in adults, the condition is called as acromegaly. Okay, so what exactly is acromegaly? Excessive amount of growth hormone in adults. For example, this is the image based question which is very important. Image based question of a patient who is suffering with acromegaly, where you can see there is protruding jaw which is called as prognathism. Okay, prognathism. Prognathism means there is a protruding jaw. If you look at the face of this person, there will be a frontal bossing, there will be big forehead, and the fingers, the toes, the palms, the soles, everything is going to be bigger in size. And if you look at the tongue of this patient, the tongue is also very much bulky in nature. That's called the macroglossia. Okay, macroglossia, big tongue, big foot, big soles, big fingers, prognathism, bigger forehead. All these are the features of a patient who is having excessive amount of growth hormone in adulthood, or the condition which is called as acromegaly. Now, after seeing acromegaly, now let's talk about Laurent dwarfism. But this was the question which was asked in one of the exam just before going to the Laurent dwarfism. Now, if they gave you this image based question, and if they ask you, this patient is at a risk of developing which metabolic disorder? See, this patient is acromegaly patient, right? Yeah, acromegaly means more growth hormone. More growth hormone means more blood glucose levels. More blood glucose levels means diabetes mellitus. So the patients who are suffering with acromegaly, they are at risk of developing diabetes mellitus. Okay, so don't forget. Now, what exactly is Laurent dwarfism? Laurent dwarfism means the patient is having defect in growth hormone receptors. Okay, the patient is having defect where? In growth hormone receptors. The growth hormone receptors are desensitized, they are not working properly. Now, in this condition, in Laurent dwarfism, what is the height of the patient? What is the height of the patient? See, growth hormone is there, but the growth hormone receptors are not functional. So, what happened to the levels of growth hormone in the body? There is excessive amount of growth hormone. Okay, growth hormone is there, but the receptors are not functional. There is a receptor resistance is there. Okay, so the patient is going to be dwarf. But if you look at the levels of ILGF, in a question if you see ILGF levels are low, definitely the question is going to be, the examiner is asking you about the Laurent dwarfism. Why the ILGF levels are low? ILGF is nothing but the somatomedian C. ILGF is nothing but somatomedian C. I have already explained to you, growth hormone when it acts on the liver, it will be converted into insulin like growth factor or somatomedian C. Now here growth hormone is there, but the receptors are not functional. So automatically ILGF levels and somatomedian C levels are going to be decreased. So in Laurent dwarfism, just tell me, in Laurent dwarfism, what are the problems? In Laurent dwarfism, the growth hormone receptors are defective. Second thing, growth hormone levels is normal or even increased, but ILGF levels or somatomedian C levels are decreased. Okay, done. Now after this, let's talk about important points for the thyroid hormone. In thyroid hormone, the first important MCQ which I want you to know is, see, in the process of production of T3 and T4, there are many important steps which are happening in the thyroid gland. In the process of making T3 and T4, there are many important steps, out of which 3 important steps are very important for your exam. What are they? Oxidation, organification, and coupling reaction. Oxidation, organification, and coupling reaction, these are the steps in making T3, T4. Now, all these steps, oxidation, organification, coupling reaction, they are mediated with the help of an enzyme. Okay, what is that enzyme? Thyroid peroxidase, TPO. The most important enzyme in making of T3 and T4 is thyroid peroxidase, TPO, also called as a TPO. Okay, the same enzyme causes oxidation, organification, as well as coupling reaction. Now, after this, I want you to know what exactly is Wolff-Chaikoff effect. Okay, many times asked in your exam, Wolff-Chaikoff effect. What exactly is Wolff-Chaikoff effect? Wolff-Chaikoff effect means whenever you give Lugol's iodine to the patient, okay, whenever you give Lugol's iodine to the patient, see, why we are giving Lugol's iodine is a total different topic. Okay, usually before surgeries we will give Lugol's iodine. Now, what happens if you give Lugol's iodine continuously in high doses? This Lugol's iodine decreases the T3 T4 production. So giving Lugol's iodine decreases the T3 T4 production. This effect is called as a Wolff-Chaikoff effect. Okay, so not only the T3 T4 production is going to go down, the vascularity, the blood supply to the thyroid gland goes down. as well as the size of the thyroid gland also decreases. There is shrinkage in the size of the thyroid gland. There is decrease in the blood supply to the thyroid gland, as well as the T3 T4 production also goes down. This effect is called as Wolff-Chaikoff effect. Now, after seeing Wolff-Chaikoff effect, let's discuss about the George-Basidoff's effect. What exactly is George-Basidoff's effect, sir? George-Basidoff effect means, see, whenever you give radioactive iodine, okay, this is not Lugol's iodine. Iodine induced hyperthyroidism. In the previous condition, say here in Wolff-Chaikoff effect, what is happening? You are giving iodine. What is happening to T3 T4? Going down means hypothyroidism. So Lugol's iodine induced hypothyroidism. See, try to understand like this. Whenever you give Lugol's iodine, T3 T4 production is going down. That is Wolff-Chaikoff effect. Now, right now, what I am discussing is the George-Basidoff's effect. Here in George-Basidoff's effect, see, you are giving iodine. Now, why you are giving iodine here? It's because, see, for iodine scan, radioactive iodine scan, okay, RAI, radioactive iodine you are giving. So, whenever you are giving this radioactive iodine, all this radioactive iodine will go and where it will concentrate? It will concentrate in the thyroid gland. And all this radioactive iodine will be utilized for the production of T3 T4. So, more amount of T3 T4 is being produced because you gave lots of iodine. That iodine is getting utilized for the T3 T4 production. This is iodine induced hyperthyroidism. When it will be seen, George-Basidoff effect is usually seen after radioactive iodine scan. Now, after seeing George-Basidoff's effect, also know about thyrotoxicosis factitia. What exactly is thyrotoxicosis factitia? See here, the patient is having means thyroid hormones, toxicosis, the toxic effects of thyroid hormones, the side effects of thyroid hormones. Because of the excessive presence of thyroid hormones, the side effects are being seen. So, thyrotoxicosis factitia means the patient, because the patient have taken excessive intake of thyroid hormones from outside, from exogenous source. The patient by somehow have taken excessive amount of T3 T4. Now this excessive amount of T3 T4 which has entered into the body is showing the toxic side effects, that is thyrotoxicosis factitia. Okay, so due to excessive intake of thyroid hormones. Okay, instead of taking one thyroxine tablet, if you take 2-3 thyroxine tablets, that causes thyrotoxicosis factitia. Okay. Now, let's talk about the functions, guys. Guys, is it everything clear? I'm going little fast, I know, but is it okay, everyone? I'm just checking the comment section. Is it okay? John Wick wanted OBGYN session. Definitely we will do. General life sessions of OBGYN will also be done. Okay, general topics like every week one topic of OBGYN will be done. Okay, so I'm just continuing. Okay, now functions. What are the functions of the thyroid hormones? Now, see, thyroid hormone, is it an anabolic hormone or is it a catabolic hormone? Guys, don't forget, growth hormone it is an anabolic hormone. Growth hormone is an anabolic hormone. But thyroid hormones, they are catabolic hormones. Okay, they are catabolic hormones. So because they will break down everything. See, they will cause glycogenolysis, causes increased blood glucose levels. Now you can ask me, sir, growth hormones increase the blood glucose level, so that we call growth hormone as a diabetogenic hormone. Even yes, thyroid hormones also increase the blood glucose levels. So yes, they are also diabetogenic hormones, true, no doubt. See, most of the students, again I am repeating, most of the students will think insulin will decrease the blood glucose levels, glucagon will increase the blood glucose levels. Only in student mind, this will be only there. Okay, glucagon increase the blood glucose levels. But also remember, not only glucagon, growth hormone increase the blood glucose levels, thyroid hormone increase the blood glucose levels. Later I will say cortisol increase the blood glucose levels. Catecholamines, norepinephrine increase the blood glucose levels. All these hormones increase the blood glucose levels, guys. Okay, not only glucagon, other hormones will also increase the blood glucose levels. Right now we are discussing about the thyroid hormone. The thyroid hormone also increases the blood glucose levels. By acting on the adipose tissue, it causes lipolysis, increase the lipolysis. Thyroid hormones break down the fats, true. Thyroid hormones also break down the proteins. It breaks down everything. That's the reason why we are calling it as catabolic hormone. Very, very important point. Which hormone have main role in maintenance of the basal metabolic rate? The basal metabolic rate is maintained by the thyroid hormone, increases the basal metabolic rate. Here I am not going into explanation. If someone asks you in exam if they ask you how thyroid hormone increases the basal metabolic rate? I'm just giving you one single line answer. Just go with it. Thyroid hormone increases the basal metabolic rate by increasing the number of sodium, potassium, ATP ases on cell membrane. Okay, this is the single best answer which I want you to answer. How T3 T4 increases the basal metabolic rate? Direct answer is by increasing a protein called as sodium potassium ATPase on the cell surface. Now thyroid hormones also have play 1 minute. Yeah, thyroid hormones also plays a very important role in the maintenance of the body temperature. That's a thermogenic. Thyroid hormones they play a main role in the formation of the synapses during the development of the baby. So brain development is very important function. And see, thyroid hormone increases the heart rate. Everyone knows thyroid hormone increases the bone growth also. You can ask me why you are telling all these points before exam, sir. Before exam, is it important? Yes, because see, if a patient is suffering with a condition called as congenital hypothyroidism, okay, if the patient is suffering with congenital hypothyroidism, what exactly I mean by congenital hypothyroidism? By birth itself, the T34 hormone levels are very much less in the baby. Now this baby is going to suffer with a condition called as a cretinism. This baby is called as cretinism. Now if you ask me what are the clinical features of cretin, this baby is no T3 T4, so no brain development. So these babies are going to be mentally retarded. And if you look at the growth of this baby, they will be having stunted growth. Okay, dwarfism. So don't ever think that dwarfism will only be because of growth hormone deficiency. Dwarfism might be because of also cretinism, where T3 T4 hormone levels are very much deficient. Okay, very important point about the thyroid hormone is, see, the thyroid hormone, this hormone is there, right? T3 T4. The thyroid hormone, where does it have its receptor? On the cell surface? No. Thyroid hormone have its receptors inside the nucleus. Intranuclear receptors are there. Very, very important point. Thyroid hormones, where do they have receptors? Intranuclear receptors. So thyroid hormone have very, very important point. Put 5-star marks. Thyroid hormones have intranuclear receptors. Okay. Now, if I just want to ask one more important point from your biochemistry. I just want to test your biochemistry, which is very easy question. Thyroid hormones, they are derived from the single amino acid. Thyroid hormones are single amino acid derived hormones. From which amino acid? Come on, guys. Thyroid hormones are derivative of which amino acid? Come on. Thyroid hormones are derived out of. Come on. Please answer. Muhammad Rizwan, Kishore, Rashid, Muhammad Hazik, you are excellent. Yes, you are true. Tyrosine. So tyrosine, very, very important question which was asked many times in the exam. Thyroid hormones are derived out of tyrosine. Tyrosine is a amino acid. Tyrosine is a amino acid. Okay. And these thyroid hormones T3 T4, it have receptors where the receptors are present in the inside the nucleus. Okay, well and good. Now here I just want to ask you two more important questions. If I am having excessive amount of T3 T4, okay, in my body there is excessive amount of T3 T4, so definitely I am suffering with which condition? Hyperthyroidism. Now what is the most reliable sign of hyperthyroidism? The most reliable sign of hyperthyroidism, see here in the features I have shown you, thyroid hormones increases the heart rate. Normally in you and me, when our heart rate will be increased, when your heart is going to be pounding. Okay, of course whenever you see your crush, automatically your heart is going to go crazy. But anyway, when your heart rate is going to be increased, whenever you do workouts, whenever you do certain amount of activity, heart rate increases, right? Whenever you do activity, heart rate increases. But in a normal person, whenever you are calm and relaxed, the heart rate is going to be absolutely normal. But those patients who have excessive amount of T3 T4, they have something called as resting tachycardia. Resting tachycardia. Okay, I'm not asking about the test, I'm asking about the sign, okay, on physical examination. Resting tachycardia or sleeping tachycardia. Okay, even during sleep, heart rate is more than 100. Now hypothyroidism, what is the most reliable sign of hypothyroidism? The most reliable sign of hypothyroidism is hung up, ankle jerk. Hung up ankle jerk. Whenever you perform ankle jerk, okay, whenever you do ankle jerk, that ankle jerk is going to be hung up. Okay, it's not how to say, how I can't show you my ankle, but whenever you tap with your hammer on the ankle, like there will be a very slow response. Okay, there will be very slow response. That's called as a hung up ankle jerk. Now, after this, let's discuss about a few important points about the insulin. Now, just tell me, insulin, favorite question. A lot of questions will be asked from the insulin. Insulin is produced from, it is produced from pancreas, everyone can say. But which cells of the pancreas? Many times question asked beta cells of pancreas. Okay, the beta cells of pancreas is the one which is going to produce the insulin hormone. Now, hormone which is produced in equimolar concentration. See, for example, if 10 molecules of insulin is produced, same 10 molecules of other hormone is also produced from the same beta cell. See, imagine this is a beta cell. Imagine this is a beta cell. Now, this beta cell is producing insulin, no doubt. Now, if it is producing 10 molecules of insulin, the same 10 molecules of other hormone will be produced. If this beta cell is producing 100 molecules of insulin, same 100 molecules of other hormone is produced. What is that other hormone which is produced in equimolar concentration along with insulin? Can you tell me? Can you tell me? Excellent, Eunice. You are true. It is C peptide. The C peptide. Okay. So the C peptide, by looking at the urinary C peptide levels, you can estimate the endogenous production of insulin. So the C peptide is a marker of, see, the C peptide, the marker of endogenous insulin production. The marker of endogenous insulin production. By looking at the urinary C peptide levels, you can know how much amount of insulin is being produced. Now, insulin is stored along with. Insulin is stored along with. Insulin is stored inside the vesicles. Everyone knows in the beta cells of pancreas, there are vesicles which contains the insulin. Insulin is stored along with which ions? Can you tell me? Eunice, can you tell me? Insulin is stored along with. Insulin is kept along with certain ions, sodium, calcium, magnesium. With which ion? Can you tell me? It's stored along with zinc ions. Okay, it's stored along with zinc ions. Why? Why? Because zinc increases the stability. Okay, why? Because insulin is a protein, right? It cannot easily undergo denaturation. To increase the stability, okay, insulin is stored along with the zinc ions inside the vesicles. Now here, I just want to ask a question from the pathology as well as from the internal medicine point of view. Why? Because this was the question. This is the question. This is a question which was asked in the, I think, the previous FMGE exam. Deficiency of zinc. Okay, deficiency of zinc causes which disease? Deficiency of zinc causes which disease? Anyone? Can you tell me? Deficiency of zinc causes which disease? Come on, guys. You are all exam going batches. There is a disease which starts with the letter A. Now, pellagra is, see, Rao, Vineet, pellagra is disease something because of vitamin B3 deficiency, I think. Okay, pellagra is due to deficiency of vitamin B3. Okay, B3. Yes. Okay, where you will, where the patient is going to have that Cazal's necklace. Okay, the Cazal's necklace is going to be seen because of the dermatitis. Because of the dermatitis component, the patient is going to have the Cazal's necklace. That's a pellagra, totally different thing. It is acrodermatitis. Intropathica. Very, very important disease. Okay, so deficiency of zinc causes acrodermatitis, entropathica. Never ever forget this before going to the exam. Now, insulin structure. Insulin is made up of alpha chain, beta chain. Not really important for your exam. Now, next question. The beta cell, it sensitizes the blood glucose levels with the help of which transporter? MCQ. See, whenever your blood glucose levels is increasing, whenever your blood glucose levels increases, now what is beta cell should have to do? The beta cell should have to release the insulin. Now how come this beta cell knows what is the blood glucose levels? How beta cell, it senses the blood glucose levels. How means on the beta cells there is a channel called as GLUT2, GLUT2. GLUT2 is a two-way transporter, With the help of this GLUT2 transporter, all the time beta cell, okay, let me show you. See, this is the blood vessel. Here is the blood vessel. This is the beta cell. Okay, this is the beta cell. Now there is a channel here which is called as a GLUT2. Now this GLUT2 channel, it allows the blood glucose levels. So that this beta cell, it all the time knows what is the blood glucose levels. If blood glucose level increases, automatically via the GLUT2 channels, glucose is going to enter into the beta cells, and beta cells now it will release insulin. Now next question is, see, now in the blood glucose levels are elevated, no doubt. You have taken a heavy meal, your blood glucose levels are elevated. Now what should happen? Now this beta cell, it have to release the insulin into the blood. Why? Because insulin will decrease the blood glucose levels. Now my question is, see, in the here beta cell is having vesicle with lots of amount of insulin, Now next question, please concentrate. See, this is the question. Insulin release from the beta cells occurs with the help of closure of which channels? Now if you want to release insulin out of the beta cell, now you need to close certain channels. Which channels? Very, very important. Lot of times this question has been asked. The question is, you need to close ATP sensitive potassium channels. So by closing the ATP sensitive potassium channels on the beta cells, you can release the insulin. Or the question can be asked something like this: ATP sensitive potassium channels are present on beta cells of pancreas. Okay, Okay, now normally all your body cells, they require insulin. They require insulin for the uptake of glucose. Mainly your skeletal muscles as well as adipocytes. They require insulin for the uptake of glucose into them. But there are two tissues in your body which doesn't require insulin at all. They don't require insulin. Even without insulin, all the time they can uptake the glucose from the blood. Now can you tell me, insulin independent glucose uptake is seen in which organs? Excellent, Eunice. This is brain, that is your central nervous system, as well as RBC. Okay, Eunice, you are saying heart is not the thing, it is the RBC. Okay, brain and RBC are the two important systems which can utilize, there is something, a word called as a basal uptake of glucose. Very, very important keyword, basal uptake. Okay, basal uptake of glucose is seen in brain as well as RBC. Okay, now insulin, it acts on which cells? Okay, via which receptors? Normally insulin, it's coming. Now let me show you. These are the insulin molecules. Now insulin molecules are coming from the beta cell. This is the beta cell. Now beta cell is releasing the insulin. Now where this insulin will come and work? This insulin will come and work on the skeletal muscles. In order to work, it have to act on a receptor. So what is that receptor? So important MCQ is acting via which receptor? Can you tell me? Insulin is acting via which receptor? Anyone? Insulin is acting via? I'm asking about the receptor of insulin. What is the receptor of insulin? Guys, you are all exam going batches. Come on. Insulin is acting via which receptor? Excellent, Eunice. It's a tyrosine kinase receptor. Okay. So insulin is acting on tyrosine kinase receptors. Next important MCQ is, what is the action of insulin on ions? Okay, if I take an insulin shot, if I take a subcutaneous shot of insulin, what happens with the ions, especially with one ion? That ion is potassium influx will occur. The moment you take insulin will cause movement of potassium into the cells, influx of potassium, okay, influx of potassium. So insulin causes potassium influx. Okay, now after this, see here guys, in this chart I am showing you, okay, sorry, in this table I am showing you the hormones which increase the blood glucose levels. Before the class you only know glucagon is the one which increases the blood glucose levels. Now what I have taught you is not only glucagon, growth hormone increases the blood glucose levels, thyroid hormone increases the blood glucose levels, cortisol as well as catecholamines. We haven't discussed about the cortisol yet, but just trust me, not only glucagon, growth hormone, thyroid hormone, cortisol, catecholamines. Catecholamines means epinephrine or epinephrine. Everyone increase the blood glucose levels. Okay, everyone increase the blood glucose levels. But who decrease the blood glucose levels? Blood glucose levels are decreased by insulin. Everyone knows. Okay, now the next kind of question that can come in your exam is who increases the insulin? Forget about the blood glucose levels. What are the stimulants for the release of insulin from the beta cells? See, first thing, blood glucose, every student knows if there is more amount of blood glucose levels, automatically insulin is released from the pancreas, first thing. And glucagon, guys, this is my favorite question. This is the favorite thing. If I am the examiner, definitely I will give you this. Okay, this is very important point. Normally students think insulin and glucagon, they are exactly antagonistic. Students will think like that. But remember, glucagon actually helps in release of insulin. The glucagon, see, just think like this. Glucagon, what it will do? Glucagon, normally, it increases the blood glucose levels or not? Yes, sir. Glucagon increases the blood glucose levels. You want this glucose where? You want the glucose to enter into the cells. So automatically, on the other hand, glucagon will also stimulate the release of insulin. Now, what this insulin will do? This insulin will take this glucose into the cells. So what I am saying is glucagon actually helps in the production of insulin, helps in the release of insulin. Okay, know this one point. Now, along with glucagon, other GI hormones, GID hormones like secretin, gastrin, cholecystokinin, secretin, gastrin, cholecystokinin, all of the GI hormones, like also like incretins, everyone increases the blood glucose levels. Sorry, not blood glucose levels, insulin levels. Insulin levels will be increased. Now, guys, see, there is a drug which was a question previously. This drug which is called as the sulfonyl ureas. Okay, sulfonyl ureas which were used by the diabetic patients. Imagine I am having diabetes mellitus. Okay, I am having diabetes mellitus. Now what I will do? Now I am taking this drug called as sulfonyl urea. Now what the sulfonyl urea will do? Can you tell me what is the drug? What is the mechanism of action? The mechanism of action of sulfonyl urea. Guys, can you tell me what is the mechanism of action of sulfonyl urea? See, I am a diabetic. You have to treat me. You have to decrease my blood glucose levels. How? By giving sulfonyl ureas. Now, see, the sulfonyl ureas, the mechanism of action, very important. MCQ. It blocks ATP sensitive potassium channels on beta cells. Very simple. Okay, whenever you take drugs like sulfonyl ureas, the ATP sensitive potassium channels are going to be blocked. Whenever the ATP sensitive potassium channels are blocked on the beta cells, automatically cell will undergo depolarization. The depolarization of the beta cells will release insulin. For your exam, what you need to keep in mind, simple, all these concepts, even if you don't know, right now this is not a time to understand the concepts. You need to know all the important points. Sulfonyl ureas, what they will do? What is the mechanism of action? Block ATP sensitive potassium channels on the beta cells. Okay, increase the insulin levels. Whenever you increase the insulin levels in diabetes patient, that's good. Okay, that's good. Now, after this, let's talk about the next fellow. Okay, next fellow in our endocrinology, that's the cortisol. Okay, cortisol. Now, cortisol, my question, is it a catabolic hormone or is it an anabolic hormone? If you are really good, just tell me. Cortisol is an example of catabolic hormone or anabolic hormone. Come on, guys. Anyone? Excellent. Cortisol is absolutely catabolic. Catabolic hormone. Cortisol is also called a stress hormone. Okay, stress hormone. Now what it will do to the proteins, what it will do, it's a catabolic hormone, right? So it proteolysis causes proteolysis. Even carbohydrates will be broken down, so it increases the blood glucose levels. It increases the blood glucose levels. What happened to the lipids? What happened to the lipids? Again, catabolic lipolysis. Lipolysis. What is the action of cortisol on the bone? Everything destructive. Cortisol is a destructive fellow. So there is bone destruction. Okay, activation of osteoclast. Okay, cortisol actually activate the osteoclast, so bones are going to be destroyed. See, remember all these points are important. Why they are important? Because at the end you will understand. Okay, so osteoclasts are activated, so bones are going to be destroyed. Now what is the action of cortisol on the blood vessels? If you can really tell me the answer, you are awesome. What is the action of cortisol on the blood vessels? Cortisol on blood vessels. Cortisol causes vasoconstriction. Okay, causes vasoconstriction. It causes BP. Okay, increases the BP, elevates the blood pressure level, blood pressure. Now what is the action of cortisol on the GIT? Okay, see, in GIT cortisol increases the acid production. Okay, it increases the acid production in the GIT. Now on the reproductive system, see, cortisol itself is a stress hormone, right? Cortisol itself is a stress hormone. Whenever you are in stress, reproductive activity is not that good in stress conditions. So whenever you are in stress, cortisol is getting released. Now this cortisol, it inhibits the reproductive activity. Okay, it inhibits the reproductive system, which means FSH levels goes down, LH levels goes down. FSH levels, LH levels are going to be decreased. Now what is the action of cortisol on the immune system? Immune system is going to go into sleep, that is immunosuppression. Okay, in here immunosuppression. The immune system was kept to sleep. Now why I have discussed all these points is because, see, there is a condition called as Cushing syndrome. Okay, there is a condition called as Cushing syndrome. What exactly is this Cushing syndrome? The Cushing syndrome is a condition where there is elevated amount of cortisol. If the cortisol levels in the body, if they are elevated, means the person is going to suffer with Cushing syndrome. Now just tell me, if I am having Cushing syndrome, what kind of clinical features will be there? What kind of clinical features are seen in patient who is having Cushing syndrome? Already I have discussed with you. See, when the patient is having excessive amount of cortisol, cortisol will cause vasoconstriction, vasoconstriction will cause BP, so the patient is suffering with hypertension. Cortisol, catabolic hormone, muscle destruction, proteolysis, so the patient is having muscle wasting, the patient is getting leaner and leaner, muscle wasting is seen. Okay, and what the patient, these patients are going to have something called as centripetal obesity. Okay, first let me show you, and after that I will explain you. See, this is how the patient is going to look like. Especially the axial skeleton of the body is going to be more fluffy. There will be a central obesity, moon face, buffalo hump, all these things are going to be seen. Now you can ask me, why this patient is having all these things, sir? You have said as cortisol, it causes the lipolysis, destruction of the fats. How come the patients became obese? See, normally cortisol, see, remember cortisol, I have already taught you, it increases the blood glucose levels. Okay, cortisol is a stress hormone. To encounter the stress, it increases the blood glucose level so much amount of blood glucose levels are elevated. Now, whenever so much amount of blood glucose levels are elevated, now whenever you have a lot of glucose, insulin production is increased. First, increase glucose lead to increase insulin levels. Now, do you know what actually this insulin will do? The excessive amount of this insulin will cause adipocyte hyperplasia and hypertrophy. That adipocyte hyperplasia is the one responsible for moon face, buffalo hump, and the central obesity. So that is the reason why the patients of Cushing syndrome are having central obesity or centripetal obesity, buffalo hump, buffalo hump, and moon faces, the round face. Okay, if you look at their abdomen, there will be abdominal striae because of the centripetal obesity. There is abdominal striae. Abdominal striae are nothing but the stretch marks. Okay, you can clearly see here the stretch marks. Now these patients are having a complaint of easy bruisability. Guys, this clinical feature is very important. Put 10 star marks. So in a question, if you get the patient is having hypertension, a weakness of the muscles. Weakness of the muscles is because of the muscle wasting. Patient is having hypertension, weakness of the muscles, easily getting fatigued, The patient is having a round face with easy bruisability, easy bruisability. Now, why this patient is having easy bruisability? Why? Because protein destruction, guys. Okay, skin is made up out of collagen. The blood vessels are made up out of collagen. The blood vessels became more friable. The blood vessels are easily getting torn out. So, blood leaking, hemorrhage is happening. Okay, so the patient is having easy bruisability. And I have also taught you immunosuppression. Cortisol causes immunosuppression. Okay, and cortisol increase the blood glucose levels, causing hyperglycemia. Cortisol will cause hyperpigmentation in a patient who is having excessive amount of cortisol. That's a Cushing syndrome. The patients usually have hyperpigmentation. Okay, too much darkening of the skin. Why there is a hyperpigmentation is because, see, a Cushing syndrome patient is having higher levels of ACTH. Okay, there is pituitary gland. Pituitary gland, there is a tumor. Okay, adenoma. This adenoma is producing excessive amount of ACTH. This ACTH ultimately will help in production of too much amount of cortisol. That's a total different thing. Now, what here I am saying is, this excessive amount of ACTH, this ACTH hormone, it's having a capability to stimulate the melanocortin receptors. So that excessive amount of melanin is produced, that causes the hyperpigmentation. So very, very important point regarding the Cushing syndrome. Never ever forget easy bruisability, hyperpigmentation, round faces, proximal myopathy, or the muscle wasting. The patient is going to have muscle wasting. Okay. Now, after this, what else can be seen in this patient who is having Cushing syndrome? Amenorrhea. Why there is amenorrhea? Why? Because the entire reproductive axis, the FSH levels goes down, FSH levels goes down, LH levels goes down. Without FSH and LH, the patient cannot have her normal regular menstrual cycles. So there is amenorrhea. The patient can suffer with hirsutism. Okay, hirsutism. Hirsutism is excessive growth of the hair. Excessive growth of the hair. Why there is excessive growth of hair? I just don't want to get into detail. It takes a lot of time. Just remember, the patient will have hirsutism. Peptic ulcer disease. This is very, very important. Cortisol increases the acid production in the stomach. I have explained to you. Cortisol increases the acid production in the stomach. More amount of cortisol, more acid production in the stomach causes peptic ulcer disease. Cortisol will cause activation of the osteoclast. Osteoclast will cause bone resorption. Bone resorption will cause osteoporosis. The patients of Cushing syndrome will suffer with osteoporosis. Osteoporosis. If you look at these patients will something look like the appearance of the patient, the physicality of these patients will something look like lemon on stick appearance. Okay, the lemon on stick appearance. In here you can see the female with excessive amount of facial hair. There is a hirsutism. Okay. So with this, we are done with the endocrinology. Okay, endocrinology is done. Now after this, let's start with general. Okay, first of all, renal is there, right? Let's go with the renal also. Okay. Now in renal physiology, what are the important MCQs which you need to know before going to the exam? See, first of all, what are the functions of the kidneys? The few important functions you should know. In the exam, they will ask you. Erythropoietin is getting produced from the kidneys. Everyone knows erythropoietin. But the important MCQ is erythropoietin is getting produced from the which cell? Erythropoietin is produced from interstitial cells of peritubular capillaries. This word is important. Interstitial cells in the peritubular capillaries. Okay, see, if this is the nephron. Okay, I'm just showing you the nephron in a simple way. If this is the nephron is surrounded by the blood vessels. These blood vessels are called as the peritubular capillaries. So the cells of this blood vessel, the interstitial cells of this peritubular capillaries are the ones which produces the erythropoietin. Erythropoietin helps in the production of RBCs. Everyone knows. Now your nephrons or your kidneys have a capability to produce an enzyme called as renin. Renin. Now this renin is produced from which part of the kidney or which part of the nephron? It's a juxtaglomerular cells. The juxtaglomerular cells of your kidneys are the ones which produces the renin. Very, very important. Juxtaglomerular cells. Next, your kidneys are also having a function of activation of vitamin D. Vitamin D is activated in the kidney. In which parts? In which part? In which part of the nephron? Vitamin D activation happens in the proximal convoluted tubule. Everyone knows nephron have PCT, DCT, loop of Henle, collecting duct, collecting tubules, all this stuff. Activation of vitamin D happens in the proximal convoluted tubule. Now, with the help of which enzyme in the proximal convoluted tubule, there is an enzyme called as alpha-1 hydroxylase. This alpha-1 hydroxylase, okay, this alpha-1 hydroxylase is an enzyme in the PCT cells, which helps in the activation of vitamin D. Okay. Now this alpha 1 hydroxylase, it's under the control of which hormone? There is one more hormone. There is a higher center. That hormone controls the activity of alpha 1 hydroxylase. Who is that? Parathyroid hormone. So what I am saying is, first thing, parathyroid hormone. This parathyroid hormone activates alpha 1 hydroxylase. Whenever alpha 1 hydroxylase is activated, then inactive vitamin D will be converted into active form of vitamin D. Where? In the PCT cells. The PCT cells. Okay. Now my question, lots of time this question was asked. Now vitamin D, what is the action of vitamin D? Vitamin D increase the blood glucose level, vitamin D increase the blood calcium levels or not? Yes, it do. Vitamin D increase the blood calcium levels as well as blood phosphate levels. How? How means vitamin D goes to the gastrointestinal tract. In the gastrointestinal tract, with the help of a protein, this vitamin D, it incorporates a protein called as calbindin. Very, very important, calbindin. So with the help of a protein called as calbindin, now this calbindin will help in absorption from the JT, helps in absorption of calcium as well as phosphate. Okay. Now you know about the vitamin D. Can you name me what is the active form of vitamin D? Here I just want to ask you, just checking. What is the active form of vitamin D? What is the name of active form of vitamin D? Can you tell me? What is the name of active form of vitamin D? Come on, guys. What is the active form of vitamin D? Is it calcitonin? Is it calcitriol? It is calcitriol. Okay, it's a calcitriol, or also called as 1,25 dihydroxycholecalciferol. 1,25 dihydroxycholecalciferol, which is the active form of vitamin D3. Vitamin D3 is the active form. Okay. Now after this, calcitriol, the name is something similar to calcitonin, right? The name is something similar to calcitonin. Okay. Now just tell me, what is the function of calcitonin? So let me write it down here, the full form. Calcitonin. What is the function of calcitonin and from where it is getting produced? The vitamin D3, vitamin D increase the blood calcium levels, but calcitonin decreases the calcium levels. Very, very important. Calcitonin, it decreases the blood calcium levels. My question is, from where this calcitonin is coming? So calcitonin is actually coming from the thyroid gland. Most of the students, they will wonder, see, calcitonin, it's coming from the thyroid gland. Okay. In the thyroid gland, there are two different types of cells. Every student knows: follicular cells, parafollicular cells. These follicular cells are helping in the production of T3, T4, main hormones, thyroid hormones. Follicular cells helps in the production of T3, T4. But what is the function of these parafollicular cells? Parafollicular cells helps in the production of calcitonin. Now, I have already explained to you what is the function of this calcitonin. Calcitonin decreases the blood calcium level. Okay, calcitonin decreases the blood calcium level. Now, see, someone comes to you and asks you, calcium homeostasis is very, very important. Calcium is such an important topic which you should never ever forget. See, vitamin D3, it increases the blood calcium levels, no doubt. Who else can increase the blood calcium levels? Parathyroid hormone. Who decreases the blood calcium levels? Calcitonin. Okay. Now, after this, let's jump into the topic of renal circulation. Okay, renal circulation. First thing, who is bringing the blood to the kidneys? It's the renal arteries. Okay, see, from the abdominal aorta, renal artery is emerging out, and this renal artery is bringing the blood to the kidneys. Now, renal artery, it emerges at the level of L1 vertebra. Okay, MCQ, very, very important. Renal artery originates at the level of which vertebra? L1 level. Renal artery, it's a direct branch of, abdominal aorta. Okay, it's a direct branch of abdominal aorta. In a recent FMGE exam, this question was asked: the testicular artery in males or the ovarian artery in females, or we can say something like this also, gonadal arteries. Testicular artery, ovarian artery, they are one and the same. So, testicular artery and ovarian artery, they are also the branches of abdominal aorta. That's a direct branch from the abdominal aorta. Okay, never ever forget, the testicular artery, the ovarian artery, they are the branches from the abdominal aorta. Why I am saying this is because, like, renal artery, it's a branch of abdominal aorta. Ovarian artery, testicular artery are also branches of abdominal aorta. Okay. Now, how can we measure the renal blood flow? If someone comes to you and asks you, how can we measure the renal blood flow? Okay, renal blood flow is 1.2 liters. That is 20% of the cardiac output. Important. Renal blood flow is how much? Just if you want to have a round figure answer, 1 liter. 1 liter is the amount of blood going to both the kidneys. But how can we measure? These are the questions. These are the questions. The para-aminohippuric acid. So by injecting something called as a para-aminohippuric acid, you can actually measure the renal blood flow or renal plasma flow. Okay, the exact term what they will ask you in your exam is the renal plasma flow. Plasma flow with the help of para-aminohippuric acid. So renal blood flow or the renal plasma flow is estimated by para-aminohippuric acid. Every student knows GFR with the glomerular filtration. How much is getting filtered every minute? 125 ml. 125 ml is the glomerular filtration rate. Glomerular filtration rate. Now, how can we estimate it? Renal plasma flow estimated by para-aminohippuric acid. Glomerular filtration rate 125 ml. How can we estimate it, sir? We can estimate it with the help of certain markers like inulin, not insulin, inulin. With the help of markers like inulin, creatinine, cystatin C. So, with the help of these substances, inulin, creatinine, and cystatin C, you can actually do the estimation of GFR, that is 125 ml. Okay. Now, that kind of questions which were previously asked, how many types of nephrons are there? There are two types of nephrons. That's not the question. What are the majority type of nephrons? There are two types of nephrons. What are they? Cortical nephrons and juxtamedullary nephrons. Cortical nephrons, juxtamedullary nephrons. The majority type of nephrons are the cortical nephrons. They help in production of urine, normal urine. But what is the importance of juxtamedullary nephrons? These juxtamedullary nephrons, they constitute only 20%, but they help in concentration of urine. This was the question. Concentration of urine is done by which type of nephrons? Juxtamedullary nephrons. Very, very important. Okay. Now, after this, what else I want you to know before going to the exam? See, there is something called as a glomerular basement membrane. Okay, or the glomerular filtration barrier. See, this is the blood vessel. Here all the plasma, everything is there. This is the glomerular basement membrane or the glomerular filtration barrier. Okay. Now, important question which I want you to know is, so this glomerular filtration barrier, it's having which charge? What is the charge? Is it having positive charge, negative charge? Most of the students, I hope you already know it. The glomerular basement membrane is having a negative charge. Negative charge. Now, why this negative charge? That this negative charge is because of certain proteins called as glycoproteins. Because of the presence of, this is a keyword, because of the presence of glycoproteins, heparan sulfate, this is the MCQ, because of the presence of heparan sulfate and siloproteins. Okay, so because of the presence of heparan sulfate, siloproteins and glycoproteins, all these substances are negatively charged substances. Proteins are negatively charged substances. So because of the presence of these things in the glomerular basement membrane, it is having negative charge. Okay, it's having negative charge. Now after that, I want to ask, what exactly are fenestrations and slit pores? Fenestrations are the gaps between, slit pores are the gaps between. Okay, please look at this image. I hope you can see here. See, these are the endothelial cells. These are the endothelial cells of the capillary. This is the blood vessel. Okay, these are the endothelial cells. In between the endothelial cells, there are these gaps. These gaps in the endothelial cells, they are called as fenestrations. Okay, these gaps are called as fenestration. Now, if you look at the opposite side, here also you are having gaps between the podocytes. These are the gaps between the podocytic food processes. Now, these gaps are called as slit pores. Okay, so fenestrations, what are they? Fenestrations are the gaps between the endothelial cells. And what exactly are slit pores? Slit pores are the gaps between the podocytes. Podocytes. Okay, you need to know them. Now, let's talk about the glomerular filtration. First topic is glomerular filtration barrier. Glomerular filtration barrier is, questions has been came from this area. This filtration barrier, it's a size barrier as well as charge barrier. The example of a size barrier as well as charge barrier. What does I mean by? What does I mean by size barrier and charge barrier? Very simple. It allows only certain size substances to filter. Only certain size particles are being filtered. Okay, so it's a size barrier, which means in the glomerulus, in the nephron, only a size of 4 to 8 nanometers or even less than that. Only this size diameter particles are filtered. More than 8 nanometers, the particles are not going to be filtered. So it's a size barrier. Only it allows certain size substances to filter 4 to 8 nanometers. Now, glomerular filtration barrier is also an example of charge barrier, which means it doesn't allow negative charge substances to filter. You can ask me why, sir? Why? Because glomerular basement membrane is already negative. So negative will repel with the negative. Okay, so it's a charge barrier. Negative charge substances are not being filtered. So that is the reason why. Albumin molecule is not being filtered. Okay, albumin, it is a negatively charged thing. albumin molecule, albumin protein, plasma protein is negatively charged. Now, why it is not getting filtered? It's because it's negative charge. Glomerular basement membrane is also negative charge. So, negative charge will repel the negativity. So, in a normal healthy person, albuminuria is not seen. Okay, one important point. Now, after that, the next important topic which I want you to know before going to the exam, especially from the patho point of view as well as from the internal medicine point of view, the topic of slit diaphragm and its clinical importance. See, this is slit diaphragm. Okay, let me show you. If you don't know, okay, some students might not know it. Let me show you. See here, in between the podocytes, in between the podocyte food processes, there is something called as a slit diaphragm. Are you able to appreciate this small protein here? Now, this is something called as slit diaphragm. In exam, what kind of questions will be asked regarding that? Slit diaphragm is made up out of. Slit diaphragm, it's made out of which proteins? That important proteins are podosin, nephrin, alpha actinin 4. Podosin, nephrin, alpha actinin 4 are the proteins which are forming the slit diaphragm. Next, what is its clinical importance? Whenever there is damage to nephrin or podosin or alpha actinin 4, what happens now? Now proteins will leak into the urine, causes proteinuria. Nephrotic syndrome will occur in the patient. Okay. So now MCQs which you need to know is whenever nephrin is mutated or whenever nephrin is affected. Okay. So nephrin is affected, it causes which syndrome? It causes syndrome called as congenital nephrotic syndrome or Finnish type of nephrotic syndrome. Okay, Finnish type of nephrotic syndrome or the congenital nephrotic syndrome is due to defect in which protein? Is due to defect in nephrin. Nephrin is coded by which gene? Okay, this is also a question which was asked. NPHS1 gene. NPHS1 gene is a gene which helps in production of nephrin. Okay, which helps in production of nephrin. Now, podosin. See, this podosin is also a protein of slit diaphragm. Now, this podosin is produced from NPHS2. Okay, it is produced from a gene called as, NPHS2. Mutation of this NPHS2 will cause defect in podosin. Whenever there is defect in podosin, it again causes a nephrotic syndrome called as steroid resistant nephrotic syndrome of childhood onset. MCQ. Steroid resistant nephrotic syndrome of a childhood onset is because of the deficiency of podosin. But congenital nephrotic syndrome, please concentrate. This one. Congenital nephrotic syndrome, which is actually steroid sensitive. You can actually treat it with steroids. So, steroid sensitive congenital nephrotic syndrome is because of the deficiency of nephrin. Okay. So, don't forget. And the last MCQ which I want you to know is alpha actinin 4. Okay, alpha actinin 4. Now, this alpha actinin 4, whenever it is defective, it again causes a nephrotic syndrome called as autosomal dominant FSGS, focal segmental glomerulosclerosis. So, autosomal dominant FSGS is because of the deficiency of alpha actinin 4, which is also a slit diaphragm protein. Okay, guys. Now, after this, let's continue with the next topics, which you should know for your exam is glomerular filtration. The one important MCQ here, I just don't want you to go through all the concept now. Glomerular filtration happens or not? Yes, 125 ml glomerular filtration is happening, right? See, this glomerular filtration happens with the pressure difference. So, what is the pressure difference for the glomerular filtration to happen? It is 10 mm Hg. Okay, the pressure difference with which the glomerular filtration happens is 10 mm Hg. Difference is there. Normally, there are two forces, opposing forces are there and favoring forces are there. This is the favoring force, this is the opposing force for the glomerular filtration. The favoring force is 60 mm Hg, opposing force is 50 mm Hg. The favoring force is more. Okay, I am not going in detail about what are the favoring forces. Simply remember, guys, glomerular filtration happens with the pressure difference of how much difference? 10 mm Hg pressure difference. Okay, that's the one important point which I want you to know before the exam. Okay, now formula for GFR calculation. How to calculate the glomerular filtration rate? Previously, I have explained to you how to estimate the GFR. GFR estimation is done with the help of substances like inulin, creatinine, cystatin C. But right now I am giving you the formula. I am giving you the formula for the calculation of GFR. Calculation of GFR, the formula is UV by P. Okay, UV by P. Okay, UV by P is the formula for the calculation of GFR as well as for the clearance. Okay, in a question if they ask you calculate the clearance of a particular substance, same formula UV by P. U means urinary concentration of that particular substance. They will give you urinary concentration is this much. What is the volume of urine produced, and what is the plasma concentration of the substance? So U V by P, urinary concentration, amount of urine produced by plasma concentration. Okay, this is the formula for GFR or clearance. Next, GFR changes, the alterations in GFR. Okay, now we all know this is afferent arteriole, this is efferent arteriole. Now whenever you constrict the afferent arteriole, you are constricting the afferent arteriole, what happens to the GFR? Just tell me. See, if you constrict the afferent arteriole, no blood is coming, no blood is coming to the glomerulus, so automatically GFR decreases, automatically GFR decreases. The constriction of afferent arteriole causes a decrease in the GFR. Question is, who causes afferent arteriolar constriction? Norepinephrine and adenosine. Norepinephrine adenosine causes afferent arteriolar constriction, decreases the GFR. Done. Next thing, next scenario is, if you dilate the afferent arteriole is being dilated. Whenever you dilate the afferent arteriole, more blood is going to the glomerulus, more pressures are generated. So what happened to the GFR? GFR increases. So afferent arteriolar dilation actually increases the GFR. Next thing, let's talk about the efferent arteriole. If you constrict the efferent arteriolar constriction, what happened to the GFR? If efferent arteriole is constricted, means no blood is going out, blood is accumulating here, the blood increases the pressures over here, hydrostatic pressure will be elevated, that actually favors the GFR initially. So initially GFR increases, if nothing is going out, after some time the amount of blood coming will also decrease. So initially GFR increases, but gradually later on the GFR decreases. So this is called as a biphasic response. So constriction of efferent arteriole. So whenever you use drugs like angiotensin 2, with the help of angiotensin 2, you can actually constrict the efferent arteriole. Okay, angiotensin 2 causes efferent arteriole constriction. When efferent arteriole is constricted, means what happened to GFR? GFR initially increase, later decrease. This is a biphasic response. Okay, biphasic response. And again same thing, whenever you dilate the efferent arteriole, very easily blood is leaving. Blood is not staying in the glomerulus. If blood is not staying in the glomerulus for more amount of time, what happened to GFR? GFR decreases. So efferent arteriolar dilation, EA dilation, what happens? What happened to the GFR? GFR actually GFR decreases. Okay. Now after this, the next point which I want you to know is the alteration of GFR with the mesangial cells. Okay. Now there are cells called as the mesangial cells. Right now what I am showing you is the Bowman's space or the urinary space, or this is the Bowman's capsule, simply Bowman's capsule. Here in the Bowman's capsule, all these are the glomerular capillaries. These are the glomerular capillaries which are bringing the blood for the purpose of filtration. Now these capillaries, please appreciate, these capillaries are surrounded by cells called as the mesangial cells. Now this mesangial cell contraction and relaxation, the mesangial cell contraction relaxation can also alter the GFR. How, sir? Very simple. Now if all the mesangial cells, if they are contracted, means mesangial cells are surrounding the glomerular capillaries. If mesangial cells are contracted, means glomerular capillaries are constricted. If glomerular capillaries are constricted, means the amount of blood going through, the capillaries decreases, automatically GFR decreases. So very, very important point, mesangial cell contraction decreases the GFR. In the vice versa way, mesangial cells, if they are relaxed, what happened to the GFR? GFR increases, sir. Okay, mesangial cell contraction is brought about by MCQs. Angiotensin 2 and endothelin. Angiotensin 2 endothelin causes mesangial cell contraction. Atrial natriuretic peptide. Atrial natriuretic peptide causes mesangial cell relaxation. And even nitric oxide. Nitric oxide causes mesangial cell relaxation. So if someone comes to you and asks you mesangial cell relaxation, increase the GFR, decrease the GFR, increase the GFR. Mesangial cell contraction is brought about by substances like nitric oxide, atrial natriuretic peptide. Guys, is it clear? Shall I go forward? Okay. Now after this, the next topics which I want you to know before going to the exam is the regulation of GFR. Okay, is the topic of regulation of GFR. I just don't know why all these images which whatever I have drawn, they are being like sliced up in the while I am just transferring those images into the iPad. They got like little bit messed up. But anyway, here the topic which I want you to know is the juxtaglomerular apparatus. Okay, the topic which I want you to know is juxtaglomerular apparatus. Now, what is this juxtaglomerular apparatus? What it is made up of, and how it is important to us? The juxtaglomerular apparatus is present side to. Okay, first of all, let me draw you in a simple way. This is afferent arteriole. This is glomerular capillary. This is efferent arteriole. Here is your Bowman's capsule. This is the proximal convoluted tubule. Down here, you are having the loop, ascending loop, descending loop, thick segment, distal convoluted tubule, collecting ducts. Now, see here, there is something called as macula densa. Okay, I should show it in black color. This is something called as a macula densa. Here, there are certain cells called as granular cells. Okay, this is afferent arteriole. Right now, I am showing you afferent arteriole from this side. This is efferent arteriole. Now, please guys see, on the afferent arteriole, there are cells called as these cells, which I am showing you right now. These cells are called as granular cells, which are also called as juxtaglomerular cells, not apparatus, juxtaglomerular cells. And there are cells which are present on the distal convoluted tubule. These cells, distal convoluted tubule. These cells are called as MD cells, macula densa. So, juxtaglomerular cells, JG cells are granular cells along with the macula densa. Along with the macula densa, and along in between them, there are also certain interstitial cells. There are also certain cells which are called as extraglomerular mesangial cells. Okay, extraglomerular mesangial cells. So all these three together forms the juxtaglomerular apparatus. Direct question. Juxtaglomerular apparatus is made up out of JG cells. I have already discussed with you. The JG cells are also called as granular cells. JG cells are granular cells. Now MD means macula densa, and EGMC means extraglomerular mesangial cells. Extraglomerular mesangial cells, which I have shown in the green color, are also called as the Polkesin cells. Polkesin cells. Now all these three structures forms the juxtaglomerular apparatus. You can ask me, sir, what kind of questions are being asked from this area? Direct question. Macula densa is present on. Okay, macula densa. Where? Macula densa is present on the distal convoluted. Macula densa is present on the distal convoluted tubule, early part of the DCT. Okay, next question. What is the importance of this juxtaglomerular apparatus? It regulates the GFR. Juxtaglomerular apparatus, it regulates the GFR, which means if your GFR is going down because of some reason, if your GFR is going down, this juxtaglomerular apparatus will try to bring back the GFR to normal. If your GFR is too much increasing, this juxtaglomerular apparatus will try to bring down the GFR to normal. So juxtaglomerular apparatus, it will regulate your GFR. Okay, now questions. Let's see about the questions. Macula densa is present on where? Early DCT. Macula densa in exam, lot of times this question has been asked. Macula densa is sensitive to which ions? Macula densa working, the function of the macula densa depends on the concentration of NaCl, especially the sodium. Okay, especially sodium. So macula densa is sensitive to which levels? Sodium levels. Sodium levels. Okay. Next thing. After that, let's talk about the topics regarding the proximal convoluted tubule, the first part of the nephron. Proximal convoluted tubule, the first part of the nephron. What you should know regarding this? In the entire nephron, the one important part which is doing the maximum work is proximal convoluted tubule. Okay, highly metabolically active. So in the conditions of hypoxia, if there is hypoxia because of some reason, if there is hypoxia in the body, which part of the nephron will be highly susceptible? The highly susceptible for hypoxia is again proximal convoluted tubule, right? Because it's working more, it demands more oxygen. There is hypoxic condition in the body, less oxygen. So PCT is going to be knocked out. Okay, the first part is going to be knocked out is PCT. Now in PCT, this was also area where you can expect a question. Which substances are absorbed? At least know this thing. 100% of your glucose, okay, glucose is freely filtered. Even amino acids are freely filtered. 100% of glucose and 100% of amino acids are reabsorbed in the PCT only. So 100% of glucose, 100% of amino acids, almost 70% of water, okay, 70% of water, 70% of sodium chloride, calcium are also reabsorbed in the PCT. At least this thing. Sodium, chloride, calcium, 100% glucose, 100% amino acids, 100% water. Not 100%, 70% of water is reabsorbed in the PCT only. Now, second question which was asked is See, in PCT, water is being absorbed or not? 70% of water is being absorbed. So this type of water reabsorption is called as obligatory water reabsorption. MCQ. Obligatory water reabsorption happens in which part of the nephron? Obligatory water reabsorption, which means, see, in PCT there is no need of any hormones. There is no need of any hormones. Simply PCT reabsorbs 70% sodium, so 70% water follows. So that's what I am showing you here. Please see, 70% sodium is reabsorbed first initially. Wherever sodium goes, water follows. So 70% of water is going back along with sodium. So there is no need of any hormones. So such a type of water movement is called as obligatory water reabsorption. So obligatory water reabsorption happens in the PCT. Okay. Now second important MCQ. Now here, whatever the fluid you have in the PCT, the fluid in the PCT is hyperosmolar or hypoosmolar. Remember, 70% sodium gone means 70% of solute is reabsorbed, as well as the same concentration of solvent is reabsorbed. So same amount of solute, same amount of solvent are being reabsorbed. So the fluid in the PCT, very important. The fluid in the PCT is having isoosmolarity. The fluid is isoosmolar, very important. The reabsorption in the PCT is isoosmolar. The fluid in the PCT is isoosmolar to plasma. In plasma, 300 milliosmoles. Our blood is having how much concentration? Our blood is having an osmolarity of 300 milliosmoles. In the PCT also, the fluid is having 300 milliosmoles. Why? Because same amount of solute, same amount of solvent are being reabsorbed. So no concentration, no dilution. Okay. Now, a pathological point which I want you to know is, see, in the PCT there are transporters which helps in the reabsorption of sodium, potassium, calcium, all these transporters are there, right? There is a disease called as Fanconi syndrome. What exactly is Fanconi syndrome? What happens in the Fanconi syndrome? Fanconi syndrome is a condition where the PCT transporters are non-functional. If PCT transporters are non-functional means glucose urea, amino acid urea, like so all kind of electrolyte abnormalities can happen. So Fanconi syndrome is the condition where PCT is non-functional. Simple. If PCT is non-functional, that syndrome is Fanconi syndrome. Okay, that's it. Now after this, a pharma point of view, a pharmacological correlation, I just want you to know. See, I have already taught you in the PCT. Okay, in the PCT, glucose is being reabsorbed. 100% of glucose is being reabsorbed. Now glucose all the time, lots and lots of times. Put 5 star marks here, 5 to 10 star marks. Accepted. So that much important question. All the time glucose is reabsorbed along with the sodium. This is sodium glucose co-transporter. The transporter name is sodium glucose transporter type 2, SGLT. Okay, SGLT, sodium glucose co-transporter type 2. Now sodium is moving along with the glucose. Now my question is, you can actually block this transporter. Okay, you can actually block this transporter, so the glucose will be lost in the urine. Actually, you can use it for the treatment of diabetes mellitus patient. So in a diabetes mellitus patient, you have to decrease the blood glucose levels. So how you can decrease the blood glucose levels? By inhibiting this channel. If you inhibit this channel, all the glucose is going to lost in the urine. So what are the drugs, guys? Drugs include SGLT2 blockers include canagliflozin, dapagliflozin, empagliflozin. So canagliflozin, dapagliflozin or empagliflozin, all these gliflozin group of drugs are the inhibitors of SGLT2 channels. Okay, SGLT2 channels. Now after this, direct single line questions which I want you to know is, there are these two terms called as urinary threshold for the glucose and transport maximum for the glucose. Urinary threshold for the glucose and transport maximum for the glucose. Two values you need to know before going to the exam. The urinary threshold for the glucose is how much? 200 milligrams per deciliter. 200 milligrams per deciliter in the plasma is the value, very important. If you increase blood glucose concentration to this much, normal blood glucose levels is somewhere around 100 milligrams. Okay, in you and my body 100 120 will be there. If you increase the blood glucose levels to this much in your blood, glucose will start to appear in the urine. Glucose is now little bit leaking in the urine. So this is a urinary threshold for the glucose. Okay, glucose now it starts to appear in the urine. Now the second important point is the transport maximum. Okay, transport maximum. What is the value of transport maximum? 375 milligrams per minute. 375 milligrams per minute. If you put this much amount of glucose into the kidneys, okay, this is the filtered load. if you put this much amount of glucose into the nephrons every minute, glucose reabsorption doesn't happen. Glucose, no, not even a single molecule of glucose will be further reabsorbed upon this value more than 375. So if you increase the urinary threshold more than 3775 milligrams per minute, no glucose reabsorption happens over this value, Okay, just know this point. Transport maximum for the glucose is 375 milligrams per minute. Okay, now after this, I just want you to know previously asked questions, repeatedly asked questions. The descending limb. What are the important points which you need to know regarding the descending limb of loop of Henle? We all know loop of Henle, descending limb is there, hairpin turn is there, ascending limb is there. Now regarding the descending limb of loop of Henle, the important MCQs which I want you to know is descending limb. Is it called as a concentrating segment or relaxing segment? The descending limb of loop of Henle, is it a concentrating segment or is it a diluting segment for the urine? Descending limb is concentrating segment. This is a concentrating segment for urine. Okay, water reabsorption happens in the descending limb of loop of Henle. Water reabsorption happens with the help of which channels? Water reabsorption happens with the help of aqua porine 1 channels. With the help of aqua porine 1 channels, only water reabsorption happens. Descending limb of loop of Henle, is it permeable to solutes? Is it permeable to solutes? No, only water. Descending limb of loop of Henle is only permeable to water, not solutes. Not permeable to solutes. Okay. Now same questions. Ascending limb of loop of Henle. Ascending limb of loop of Henle, it is only permeable to solutes. But water reabsorption happens? No, water reabsorption does not happen. So water reabsorption does not happen in the ascending limb of loop of Henle. No water is being reabsorbed. In ascending limb of loop of Henle, water reabsorption does not happen. Only solutes will be reabsorbed. Okay. So that's the reason why ascending limb of loop of Henle is called as diluting segment. Diluting segment of urine. It's a diluting segment for the urine. Descending limb is concentrating segment. Ascending limb is diluting segment. Now put 10 star marks. This is such an important MCQ. Sodium potassium 2 chloride importer is present where? In the nephron, there are different types of transporters. Sodium potassium 2 chloride importer, it's present on ascending limb of loop of Henle. Okay, sodium potassium 2 chloride importer is present on ascending limb of loop of Henle. Okay. Now same, I just want to add one more point here. Sodium chloride importer, where it is present? Sodium chloride importer. So sodium chloride importer, where it is present, sir? If you ask me, sodium chloride importer is present in the distal convoluted tubule, present on distal convoluted tubule, okay, and the DCT. Now, what exactly is Bartter syndrome? Can anyone tell me what exactly is Bartter syndrome, guys? Bartter syndrome. Come on. Very important MCQ for the exam. See, by birth, if the child is having mutation of sodium potassium 2 chloride importer, sodium potassium 2 chloride importer, by birth itself, if it is non-functional, by birth itself, that causes a syndrome called as Bartter syndrome. So the direct question which will be asking your exam is, what is the transporter which is affected in Bartter syndrome? Sodium potassium 2 chloride importer. Or they can ask something like this: mutation of Bartin protein or sodium potassium 2 chloride importer will cause Bartter syndrome. Okay. Now a few more important points regarding the ascending limb of loop of Henle. The ascending limb of loop of Henle, yes, it is having sodium potassium 2 chloride importer. It's a diluting segment. Okay. Ascending limb of loop of Henle, it's having which potential? It's having inside the lumen, it's having positive charge. Okay, in the ascending limb of loop of Henle, there is a positive charge present. Now, what is the importance of this positive charge? If someone asks you, what is the importance of this positive charge? Or if someone in your exam asks you calcium and magnesium reabsorption, okay, in your exam, if they ask you calcium and magnesium reabsorption happens because of this positive charge. Calcium and magnesium reabsorption happens due to the positive charge in the ascending limb of loop of Henle. In the ascending limb of loop of Henle, there is positive potential. This positive potential will repel. The positive potential will repel the calcium and magnesium. So the calcium and magnesium are being reabsorbed. Okay. Now after this, let's talk about loop diuretics. Loop diuretics, the direct question which was asked is, loop diuretics inhibits which channels? Which transporter? Loop diuretics inhibit which transporter? Loop diuretics inhibit sodium, potassium, 2 chloride, symporter. Where it is present? In the ascending limb of loop of Henle. And thiazide diuretics. Okay, so thiazide diuretics will inhibit which transporter? Anyone? Thiazide diuretics inhibits which transporter? Thiazides. Thiazides inhibit sodium chloride symporter. Sodium chloride symporter. Now, where the sodium chloride symporter is present? On the distal convoluted tube. Okay, so these are the important points which I want you to know regarding the renal. Okay, regarding renal, I just want you to know these things. The other part, like especially with the aldosterone thing, I have already discussed it in the endocrine. Now, after this, what I want you to know, some important points from the general. Okay, general also will bring you 2-3 MCQs. Now, important topics just in next 15 minutes. Let's see what are the important points which you need to know regarding the general physiology. Okay, lots of time this question has been asked. This is your cell membrane. Okay, cell membrane. Now, cell membrane is made out of what? Proteins. Cell membrane is something made out of proteins, lipids, and carbohydrates. Proteins, lipids, and carbohydrates. The question kept on being asked in your exam is, what is the major component? The major component of your cell membrane. The major component of your cell membrane. The major component of your cell membrane is proteins. Okay, the majority of the composition of your cell membrane is coming from the proteins. No. Okay, so the majority component is coming from the proteins. Lipids constitute for 40%, carbohydrate constitute for 5%. But important MCQ I want you to know is proteins are the major components of the cell membrane. Next, there is one exception where the nerve cell membrane, in the nerve cell membrane, the majority composition is not the proteins but lipids. Okay, 80%. Done. Now this model, like this model is called as a fluid mosaic model. Right now, the model which I am showing you, that this model was proposed by two scientists, Singer and Nicholson. This model is called as fluid mosaic model. The MCQ which I want you to know from here is this fluid and mosaic model was given by scientists Singer and Nicholson. Okay, Singer and Nicholson. Now, in which cell membrane? See, in which cell membrane highest concentration of proteins is seen? I have said you, in the cell membrane, highest concentration, highest composition is for proteins only, 55%. That too, now next question is, in which cell membranes highest concentration of proteins are there? In the inner mitochondrial membrane. Okay, in the highest concentration of proteins are present in the inner mitochondrial membrane. After this, now let's talk about the lipids. Okay, now let's talk about the lipids. Lipids are of how many types? Phospholipids, glycolipids, sterol. Now, for the exam point of view, what I want you to know is, say, there are different types of phospholipids like lecithin, sphingomyelin, phosphatidylserine, phosphatidylinositol, cardiolipid. Every phospholipid, okay, every phospholipid is having one MCQ. What is that? First thing, let's start with the phosphatidylcholine, also called as a lecithin. See here, phosphatidylcholine. This phosphatidylcholine is also called as dipalmityl phosphatidylcholine or lecithin. It is a major lipid in the surfactant. Now, if in your exam, if someone asks you what is the major lipid in the surfactant, the major lipid in the surfactant is dipalmityl phosphatidylcholine or lecithin. If there is a major lipid, also there is something called as a minor lipid. The minor lipid is known as sphingomyelin. Okay, the second phospholipid, sphingomyelin. See, the second phospholipid is sphingomyelin. Lecithin is the major lipid, sphingomyelin is the minor lipid. Now, the ratio of lecithin to sphingomyelin ratio of more than 2. Okay, lecithin sphingomyelin ratio more than 2. It indicates what? It indicates fetal lung maturity. Okay, if you want to know whether the fetal lungs are matured or not, you have to check the lecithin sphingomyelin ratio. The lecithin sphingomyelin ratio, if it is greater than 2, it indicates fetal lungs are matured. Now, the third phospholipid which I want you to know is phosphatidylinositol. We have completed two. Lecithin completed, sphingomyelin completed. The third phospholipid which I want you to know is phosphatidylinositol. So, which phospholipid is acting like a secondary messenger? Okay, which is acting like a secondary messenger is phosphatidylinositol. Phosphatidylinositol acts like secondary messenger in the cell. Later, I will explain you all the secondary messengers, the three important secondary messengers. Now, right now, the phosphatidylinositol, IP3, also called as IP3, phosphatidylinositol. It acts like secondary messenger. It helps in calcium influx into the cell. Okay, it helps in calcium influx in the cell. The next phospholipid, the name of the next phospholipid is phosphatidylserine. Phosphatidylserine. Normally, see, in a cell, normally this in a healthy cell, this phosphatidylserine molecules, where they are present towards the cell, inside the cell. Okay, they are not exposed out. They are present inside the cell. Now, see, they are present in the cell. Okay, but in a cell which is undergoing apoptosis, what happens? See, in an apoptotic cell, there is exposure of phosphatidylserine. The phosphatidylserine is now flipped outwards. It's now flipped outwards. So, this is a very important point. The phosphatidylserine is actually present towards the cell. In an apoptotic cells, what happened? It is exposed outside. It is exposed outside. Whenever it is exposed outside, you can actually stain it with the help of a drug, with the help of a stain called as annexin 5. So important MCQ, annexin 5 is a dye. Okay, it's a dye with which you can actually stain the phosphatidylserine. So now, what is a marker of apoptotic cell? Annexin 5. Okay, what is a marker? What is a marker of how you can know that whether the cell is undergoing apoptosis or not? By staining it with annexin 5. Annexin 5 goes and stains what? Phosphatidylserine. Okay, phosphatidylserine. Now, after phosphatidylserine, now let's talk about cardiolipin. Cardiolipin. Guys, don't like confuse. I am going in an order. First, I have discussed about the phosphatidylcholine, sphingomyelin, phosphatidylserine, phosphatidylinositol. Right now, I am discussing about the cardiolipin. Now, important point which I want you to know regarding the cardiolipin is, see, this cardiolipin, this phospholipid is maximally present where? In the mitochondrial membranes. It's maximally present in the mitochondrial membranes of nerve cells. Okay. Important point is anti-cardiolipin antibodies. Anti-cardiolipin antibodies are seen in which conditions? There are conditions where autoimmune antibodies are produced against this phospholipid, against this cardiolipin. Now, anti-cardiolipin antibodies are seen in diseases like syphilis, Apla syndrome, and SLE. In syphilis, Apla syndrome, and SLE. Okay, in syphilis. Now, I just want to test your knowledge. Just try to answer yourselves. Syphilis is sexually transmitted disease, right? It's a sexually transmitted disease. Can you tell me it's caused by which organism? It's caused by which organism? Syphilis is caused by. Syphilis is caused by. Can you tell me syphilis is caused by? Treponema pallidum, spirochetes. Okay, spirochetes. Okay, and antiphospholipid antibody syndrome, systemic lupus erythematosus. In all these conditions, you can actually see anti-cardiolipin antibodies. Now, after this, now we have discussed all the phospholipids. All these phospholipids are completed. Now, see regarding the glycolipids. Okay, now glycolipids, I just want you to know only one important point. So, there is something called as cerebrocytes and gangliosides. These glycolipids are of two types. Glycolipids like cerebrocytes, gangliosides. Here, the important MCQ which will come in your exam is GM1 type of gangliosides. There is GM1, GM2, GM3, something like that. Now, GM1 gangliosides. These GM1 gangliosides on the cell surface, they can act as a receptor for the entry of chlorotoxin. MCQ. Chlorotoxin enters into the cell. Let me show you. Here, yes, see, the chlorotoxin, it uses GM1 ganglioside. The chlorotoxin, okay, it uses GM1 gangliosides for entry into the cell. So, chlorotoxin uses which glycolipids? GM1 ganglioside as a receptor. Now, the next concept which I want you to know is the fluidity of the cell membrane. Okay, now, if the cell membrane is having more fluidity, means more flexible, that is something good. Okay, now there are fatty acids called as unsaturated fatty acids. Now my question, unsaturated fatty acids, are they good or not? Unsaturated fatty acids are very good, very good. So unsaturated fatty acids are good, and saturated fatty acids are trans fat. The saturated fatty acids are also called as a trans fat, which are very bad. Now, as far as exam, what you should know, examples of unsaturated fatty acids and what they will do to the fluidity. Now, unsaturated fatty acids like linoleic acid, linoleic acid, and arachidonic acid. Linoleic, arachidonic acid. These are unsaturated fatty acids. They increases the they increases the fluidity. All these fatty acids, they increases the fluidity of the cell membrane or the flexibility of the cell membrane, which is something good. But whenever you consume junk foods, in those junk foods you are having a saturated fatty acids. The example of the saturated fatty acids are palmitic acid, palmitic acid and stearic acid. Palmitic acid and stearic acid. These are unsaturated fatty acids. What they will do? They decreases the fluidity. They decrease the fluidity. They make the cell membrane rigid. So regarding fluidity, you know, substances which increase the fluidity, substances which decrease the fluidity. Unsaturated fatty acids, saturated fatty acids. Now, in the exam, the question once asked is, which of the following substances acts like a fluidity buffer? Fluidity buffer. Whenever fluidity is increasing or whenever fluidity is decreasing, now there is this one molecule which acts like a buffer and try to regulate the fluidity of the cell membrane. That molecule is nothing but your cholesterol. The cholesterol in your cell membrane, acts like a fluidity buffer. Now lipids are completed. How many types of lipids are there? Phospholipids, glycolipids, sterol. Sterol is nothing but the cholesterol. Now let's see important points about some proteins. Two important proteins which I want you to know regarding the exam is spectrin and ankyrin. The spectrin and ankyrin are the proteins which are present in the cell membrane, the cell membranes of RBCs especially. Now the spectrin and ankyrin, they are present in the RBCs. And what is the importance of the spectrin and ankyrin? They are the ones responsible for biconcave shape. The biconcave shape of the RBCs is because of these two proteins, spectrin and ankyrin. Now whenever the spectrin is mutated, what happens? Do you think the RBCs are going to be in biconcave shape? No. That will cause a disease called as hereditary elliptocytosis. RBCs will become elliptical in shape, and damage to ankyrin will cause hereditary spherocytosis. So direct questions: hereditary spherocytosis is due to defect in ankyrin. Hereditary elliptocytosis is due to defect in spectrin. And apart from spectrin and ankyrin, there is also one more important protein in the cell membrane. The cell membrane protein is called as dystrophin. Dystrophin. Now the dystrophin is the largest gene. Dystrophin gene is the largest gene. Long back this question has also been asked. Dystrophin gene is the largest gene ever known in the human body. Any defect in this dystrophin will cause a disease called as a Duchenne's muscular dystrophy. I will discuss about this again later. So three important proteins: spectrin, ankyrin, dystrophin. Now after this, here I just want to ask you about a protein called as a lipid anchored protein, which is called as a GPI. Very, very important, especially from the patho point of view. On your RBCs, there is a protein called as a GPI. It's a protein. It's an example of lipid anchored protein. So lipid anchored protein. This GPI. Now, please appreciate this GPI molecule. What it is doing? It's having two hands. With one hand, it's catching DAF, and with other hand, it's holding MIRL. With one hand, it is holding DAF, means decay acceleratory factor, and with other hand, it's holding MIRL, membrane induced reactive lysis. I am the GPI. I am a lipid anchored protein who is sitting on the surface of RBCs. With one hand, I am having DAF, and with the other hand, I am having MIRL. See, this is something normal. This is something healthy also. Normally, in your blood, there are some complement proteins, right? There are complement proteins which can even kill the RBC. But why your complement proteins are not killing the RBCs? Because on the surface of your RBCs, there are molecules like DAF and MIRL. They are present. They will prevent the hemolysis. They will prevent the action of complements on the RBC. So complements cannot attack the RBCs because it's having DAF and MIRL. Now why I am saying this is because whenever you are having a defect here in the GPI, whenever you are having deficiency of this GPI, there is no DAF, there is no MIRL. What happens? RBCs will undergo hemolysis. So that disease name is called as paroxysmal nocturnal hemoglobinuria. Paroxysmal nocturnal hemoglobinuria. What is the defect? The defect is in GPI. Whenever there is no GPI, the DAF and MIRL, which are also called as the CD55 and CD59, they are not going to be present on the RBCs. Whenever they are not present on the RBCs, complements are not inactivated. When the complements are not inactivated, the RBC will be destroyed, causing hemolysis. Okay, so the patient is going to suffer with hematuria, that is paroxysmal nocturnal hematuria. In a direct question, they will ask you, in paroxysmal nocturnal hematuria, which proteins are affected? GPI. GPI is affected. So there is no DAF and no MIR. DAF is CD55, MIR is CD59. Okay. Also, I have already discussed with you the dystrophin protein. Dystrophin protein, it's having the largest gene in the human body. The largest gene in the human body is for the dystrophin protein. Mutation of this dystrophin protein will cause a disease called as a DMD, Duchenne's muscular dystrophy. When the patient is suffering with the Duchenne's muscular dystrophy, all his muscles are very, very weak. If you ask this person to squat down and if you ask this person to just stand up, he cannot just stand up like not like you and me. Why? Because his all his muscles are very much weak. So he's going to take the support of his hands, something like this. Okay, so this sign is called as a Grover sign. Okay, that sign which I am showing you here. So while he is trying to stand up, he is using all his forelimbs, with the help of his hands, he is just trying to stand. So this sign is called as a Grover sign. Okay, it's Grover, Grower, Grover sign, Grover sign. Okay, and what is the most common cause of death? The most common cause of death in a patient who is suffering with Duchenne's muscular dystrophy is respiratory distress or the respiratory muscle paralysis. The diaphragmatic paralysis will cause respiratory distress. That respiratory distress will cause the death in Duchenne's muscular dystrophy patient. Now, after this, in general, also discuss about the membrane transport. Okay, membrane transport. Now, the membrane transport is mainly divided into two types: active transport, passive transport. Right now, I am first talking about the passive transport. Okay, passive transport. Okay, passive transport. Now, what are the examples of passive transport? In passive transport, see, first point, there is no need of ATP. ATP is not utilized. What are the examples of passive transport? Two: simple diffusion, facilitated diffusion. Facilitated diffusion. Two examples of passive transport are simple diffusion, facilitated diffusion. Now, for the exam, what are the important MCQs which you should know? Diffusion is measured by using which law? Okay, diffusion is determined by using which law? Fick's law, guys. Very, very important. Fick's law of diffusion. The entire name is the Fick's law of diffusion. Fick's law is used to demonstrate the diffusion. Next thing, next MCQ which I want you to know is, see, in facilitated diffusion, okay, in facilitated diffusion, actually you need no ATP, but you need something called as a carrier protein. This is the MCQ. Carrier proteins are used in which type of diffusion? Carrier proteins are used in facilitated diffusion, not the simple diffusion. Both in simple diffusion as well as facilitated diffusion, there is no need of any ATP. Done. In active transports, okay, active transports, there are two types of active transport where energy is utilized. In active transport itself, energy is utilized. Now, I'm just giving you two examples of active transport: primary active transport, secondary active transport. Examples are very, very important. What are the examples of primary active transport? Examples of primary active transport is, you all know, sodium potassium ATPase, which is present on all the cells of our body. Throwing sodium out, bringing 2 potassium in, throws 3 sodium out, brings 2 potassium in. This is called as the coupling ratio, MCQ. What is the coupling ratio of sodium potassium ATPase? The coupling ratio of sodium potassium ATPase is 3:2. Sodium potassium ATPase is an example of primary active transport where there is a direct use of ATP. There is something called as a secondary active transport. Okay, secondary active transport. What are the examples? See, first point, all co-transporters, wherever you see, either it's a symporter or antiporter, doesn't matter. All the co-transporters, sodium glucose co-transport, sodium amino acid co-transport, sodium potassium 2-chlorine symporter, sodium iodine symporter, wherever you see co-transporters. Co-transporter means movement of ions together, either in one single direction or either in opposite direction. So all the co-transporters, symporters and antiporters are examples of secondary active transport. Okay, done. Now, next topic which I want you to know is the vesicular transport. How many types of vesicular transporters are there? Exocytosis means something is moving out of the cell. Okay, the vesicle is moving out of the cell. It's a transport via the membrane. The transport is happening. This is exocytosis. So first of all, my point, this vesicular transport, exocytosis, endocytosis, both are they active or passive? Very, very important. Both of them are active transports. Vascular transport is an example of active transport. Both of them are examples of active transport. And the kind of MCQs which I want you to know for the exam is exocytosis is mediated with the help of which proteins? Exocytosis is mediated with the help of proteins like T snare and P snare. So snare proteins. Okay, snare proteins are helping in exocytosis or endocytosis? Exocytosis. Clathrin and megalin molecules. Clathrin and megalin. These are the molecules which helps in endocytosis. Direct questions. Endocytosis, clathrin, megalin. Exocytosis, snare proteins. Okay. And for the movement of these vesicles in and out, for the movement of these vesicles, what is the most important ion required? The most important ion required is calcium. So calcium is the most important ion for the vesicular transport. Now after this, let's talk about a few important hormones and important points. Now, see the hormones which are derived of amino acid derived hormones. Okay, amino acid derived hormones. The amino acid which I am taking here right now is a tyrosine. Tyrosine is an amino acid. Already I have said to you during thyroid gland, T3, T4, thyroxine and triiodothyroid thyroid hormones are derived from tyrosine. Thyroid hormones are derived from tyrosine. Catecholamines. What are catecholamines? Epinephrine, norepinephrine, dopamine. Catecholamines are also derived from tyrosine. Now I am asking you one question. If you are really good, just tell me, guys, what is the pigment that is derived out of tyrosine? What is the pigment that is derived out of tyrosine? It is melanin. It's melanin. Okay, melanin. Now next, tryptophan. Tryptophan is an amino acid. Tryptophan, from the tryptophan, which hormone is being produced? Synthesize serotonin. So serotonin is a derivative out of tryptophan, and arginine, put 10 star marks. Okay, so from arginine, from this amino acid, we have made nitric oxide. Okay, so nitric oxide is a derivative of single amino acid, that is arginine. Nitric oxide, what is the important function of nitric oxide? Wherever you see, for your lifelong see, nitric oxide is a smooth muscle relaxant. Nitric oxide causes vasodilation. Okay, nitric oxide, it causes vasodilation. Very, very important. It causes smooth muscle relaxation. Now, let's discuss now cholesterol derived hormones. Hormones which are derived out of cholesterol. So far what we have seen, hormones which are derived out of amino acids. There are also hormones which are derived out of proteins. Amino acids are different, proteins are different. Right. So far what we have seen, amino acid derivatives. Protein derived hormones are not that important for your exam. Important point is cholesterol derived hormones, means hormones which are derivative of cholesterols, which are called as steroid hormones. So what exactly is a steroid hormone? A hormone which are synthesized out of cholesterol. Okay. Now, what are the examples? Like sex steroids, like testosterone, estrogen, progesterone, aldosterone, cortisol. Guys, we have discussed about the cortisol. Don't forget, cortisol is also derived out of a cholesterol. Cortisol, cholesterol. Okay, so sex steroids, aldosterone, cortisol, all are derived out of the cholesterol. Now, important point is, as they have derived out of a cholesterol, a fatty thing, a lipid thing, they can easily cross the cell membrane. So these hormones which I have discussed here, all these hormones, see, these hormones, they can cross the cell membranes. So where do the receptors present? Their receptors are present inside the cells, not on the cell surface. They can cross the cell membrane. Okay. Now after this, hormones which are, so vitamins which are acting like hormones. There are vitamins which can act like hormones. What are those vitamins? Vitamin A and vitamin D. Vitamin A and vitamin D, they are vitamins. Okay, they are vitamins. They are fat soluble vitamins. Okay, they are fat soluble vitamins. They can act like hormones. So as they are fat soluble, where do the receptors present? Vitamin A, D. The vitamin A and D, they can also cross the cell membrane. So the receptors, okay, their receptors are present intracellularly. The receptors are present not on the cell surface, intracellularly. So just wind it up. Intracellular receptors are present for sex steroids, cortisol, aldosterone, vitamin A, vitamin D. Okay. Now, after this, what else I want you to know is the secondary messengers, guys. The secondary messengers which I want you to know here is uh, the three important secondary messengers. These receptors not that important. Secondary messengers are very, very important. The kind of question that will come in your exam is all of the following are secondary messengers except the CAMP, the cyclic AMP in the cell. IP3, don't never ever forget the phospholipid. We have discussed IP3, phospholipid. IP3 means inositol triphosphate and DAG, diacylglycerol. So these three molecules, CAMP, cyclic AMP, IP3 and DAG, all these are secondary messengers. These molecules are acting as secondary messengers. Okay. Now, next important MCQ which I want you to know is the CGMP, which is, okay, I just forgot to, okay, anyway, okay, let me explain you here. There is a molecule called as a CGMP. Okay, see, it will also act like a secondary messenger, no doubt. But the kind of question that will keep on coming up in your exam is, see, CAMP is a secondary messenger, just like CAMP, CGMP. CGMP is also a secondary messenger. The kind of question that keeps on coming in your exam is which hormone uses CGMP as a secondary messenger for its action. The hormones are, see, nitric oxide. Just now we have discussed, no, nitric oxide, smooth muscle relaxation, cause vasodilation derived out of arginine. We have discussed. So this nitric oxide, atrial natriuretic peptide, brain natriuretic peptide, ANP, BNP, these fellows, these hormones uses, okay, these hormones uses CGMP as their secondary messenger. Repeated last MCQ is nitric oxide uses CGMP as a secondary messenger. What it will do? It will cause relaxation of smooth muscles, so that it will cause vasodilation. Okay, so what are the secondary messengers? CAMP, CGMP, IP3, DAG. These are the secondary messengers which I want you to know. Now, from the micro point of view, I want you to know there are these toxins, guys. Okay, hormones increases the CAMP, CGMP, IP3, DAG. That's a total different business. But here there are certain toxins like cholera toxin from Vibrio cholera. Already just we have discussed. Cholera toxin uses GM1 ganglioside to enter into the cell. So the same cholera toxin after entering into the cell, what it will do? Now this cholera toxin after entering into the cell, it increases the CAMP levels. Even pertussis toxin. Okay, cholera toxin, pertussis toxin, both increases the CAMP. Okay, toxins which increases CAMP is pertussis toxin, cholera toxin. Now after this, what else should you need to know? Intracellular receptors. Intracellular receptors means the receptors are present where? Inside the cell. For example, if I show you cell something like this. Now in the cell there are two compartments. Here is the cytoplasm, this is the cytoplasm, this is the nucleus. So inside the cell means the receptor may be present in the cytoplasm or the receptor may be present inside the nucleus. Now intracellular receptors are divided into how many types? Intracytoplasmic receptors, intranuclear receptors. Two types, intracytoplasmic, intranuclear. Now question is, intracytoplasmic receptors are present to which hormones? Intracytoplasmic receptors, which means the receptor is present in the cytoplasm. See, aldosterone, mineralocorticoid, cortisol, androgens, male sex corticoids, and vitamin D. Okay, all of them are having intracellular only, but even in intracellular, it is intracytoplasmic. Aldosterone, cortisol, androgens, vitamin D, all of them are having which type of receptors? Intracytoplasmic receptors. The receptor is present in the cytoplasm. Now intranuclear means the receptor is present inside the nucleus. Nucleus means in a very, like, a very private space. Okay, very enclosed space. Okay. Now why I am saying so is because there is a mnemonic which I found for myself: sex with T3 T4. Sex with T3 T4, which means estrogens. Okay, estrogens, progesterone, vitamin A, T3 and T4. Estrogen, progesterone, vitamin A, T3, T4. They are having where? They are having receptors inside the nucleus. Sex with T3, T4, mnemonic. Okay, these hormones are having the receptors inside the nucleus. Yeah. Now after this, one single important point which I want you to know regarding the cell organelles, guys. Okay. Now, protein synthesis is under the control of which cell organelle? Direct question. Lots of times asked. It's under the control of rough endoplasmic reticulum. So protein synthesis is under the control of rough endoplasmic reticulum. Now, whenever you form a protein out of all the amino acids, there should be a proper folding. Now, this folding of the proteins is done with the help of which molecules? The folding of the proteins is done with the help of chaperones. Okay, the folding of the proteins is done with the help of molecules called as the chaperones. But sometimes mishaps can happen. Sometimes there will be misfolding of proteins can occur. Okay, misfolding of proteins. Now, whenever there is any misfolded protein, that's a very toxic protein, that's a very bad protein. That misfolded protein need to be degraded immediately. So, misfolded proteins are destroyed by a system called as ERAD. Okay, what exactly is ERAD? ER means endoplasmic reticulum. ER means endoplasmic reticulum is going to destroy the misfolded proteins. So, endoplasmic reticulum associated destruction. Okay, so ERAD. So what exactly happens now? The misfolded protein, for example, if this is a misfolded protein, the misfolded protein is going to be tagged. It's going to be tagged with the help of a molecule called as a ubiquitin. The ubiquitin molecule is tagged upon to the misfolded protein. Now, this misfolded protein, which is having the ubiquitin tag, will be identified by the proteasome, will be uptaken by the proteasome, and the proteasome is going to destroy the misfolded protein. So this is called as ubiquitin proteasome degradation pathway. So ubiquitin causes the degradation of the misfolded proteins inside the proteasomes. Done. Because of some reason, if there is any defective in this ERAT, if there is any defective, sometimes what can happen? There can be accumulation of the misfolded proteins in the body. And abnormal proteins, if they are accumulating in the body, that can cause certain diseases. If these abnormal proteins are accumulating in the brain, in the central nervous system, that causes a disease called as Prions disease. Prions disease. Normal protein is PRPC. This is the normal protein, PRPC. Okay, PRPC. It's a normal healthy protein. But what happens in prion disease? That PRPC was converted into PRPSC. Okay, PRPC was converted into PRPSC, abnormally misfolded protein. Now, this abnormal misfolded protein, this prion particle, this prion protein is going to cause a disease called as Creutzfeldt-Jakob disease, an example of a prion disease where there is accumulation of the misfolded proteins in the central nervous system. And same thing, because of the misfolding of one more type of protein, there is accumulation of this misfolded proteins in the central nervous system, that is called as a beta amyloid, A beta amyloid. See, this A beta amyloid is also a misfolded protein. Okay, it's also a misfolded protein. If it accumulates in the brain, it causes a disease called as Alzheimer's disease. Okay, it causes Alzheimer's disease. Next, after this, important point about the Golgi complex. The one important point about the Golgi complex is what is the function. If you want to know one important point, it's a post-translational modification. The post-translational modification of the proteins. A modification in the proteins is done with the help of which organelle? Golgi proteins. Lysosomes. Lysosomes from your intermediate class 11th and 12th. I hope you are all studying. Lysosomes, these are called as the suicidal bags of the cells. Okay, they are called as the suicidal bags of the cells or even recycling bins. Why? Because they contains hydrolytic enzymes. Actually produce hydrolytic enzymes with the help of proton ATPase. This was the question asked. Proton ATPase is present in which cell organelle? Proton ATPase, H plus ATPase is present in lysosomes. With the help of this proton ATPase, protons means acid. With the help of this proton ATPase, more acids are being produced. Now, these acids, hydrolytic enzymes, will help in destruction of the walled cells. Okay, walled cells and walled cell organelles. Okay, so this lysosomes helps in phagocytosis. This lysosomes will cause autophagy, self-destruction, self-apoptosis, right? So, lysosomes important point, suicidal bags. Lysosomes, one more important point, they are also called suicidal bags and recycling bins. Lysosomes contain H plus ATPase, proton ATPase, contain hydrolytic enzymes. Okay, done. Now, next important point is about regarding the peroxisomes. One important point, if you want to know, peroxisomes contains an enzyme called as a catalase. Okay, what catalase will do? Catalase is a antioxidant. Catalase is an antioxidant which helps in neutralization of free radicals like H2O2, hydrogen peroxide. H2O2 is a hydrogen peroxide. That's a free radical. That's a bad guy in the body. Now, this hydrogen peroxide needs to be neutralized, and it will be neutralized with the help of an enzyme called as catalase. Catalase destroys the H2O2. Done. Now, in peroxisomes, there is a very important enzyme present. This enzyme name is called as a phytanic acid oxidase. Phytanic acid oxidase is an enzyme present inside the peroxisomes. Now, whenever you have the deficiency of this phytanic acid oxidase, it will cause a disease called as Refsum's disease. So, Refsum's disease is due to deficiency of peroxisomes. Okay, cell organelles important points are also completed. Now, a few important points regarding the cytoskeleton. Okay, what you should know regarding the cytoskeleton. The cytoskeleton in a cell mainly divided into three parts: microtubules, intermediary filaments, microfilaments. Okay, three different type of filaments. Now, microtubules include, direct question, microtubules include. Right now, I am discussing about the microtubules. Three types of microtubules are there. What are they? Kinesin, dynein, tubulin. Kinesin, dynein, tubulin. Now, see, right now, okay, if you see a neuron, something like this, everyone knows neuron have cell body and a nerve terminal. Nerve terminal. Right now, I'm not talking about the action potential, not electrical impulses. I'm talking about the transfer of the vesicles. A vesicle should have to be moving from the cell body to the nerve terminal, from the cell body to the nerve terminal. So the movement, this axonal transport is done with the help of this kinesin, dynein, and tubulin. Now you can clearly see here, see, these are tubulin molecules. These are tubulin molecules. Tubulin is also a part of microtubules, right? Now here, see, there is kinesin and a dynein. So this kinesin and dynein, actually they will work on the tubulin protein. They will move the vesicles from the cell body to the nerve terminal, and the vesicles which are emptied vesicles again will be brought back to the cell body. Okay, so these two types of transport. Now see, important point, kinesin. What the hell is this kinesin doing? Kinesin will help in movement of the vesicle from where? From the cell body to nerve terminal. This is anterograde movement, like the forward movement. So from the cell body to the nerve terminal, who is moving, who is helping in the movement of the vesicles? Kinesin. Dynein is helping in the movement of the particles or the vesicles from the nerve terminal to again back to cell body. Tubulin is just like a road. Okay, this one. Now, important MCQ which I want you to know here is rabies virus. Okay, rabies, whenever dog comes and bite you, mad dog, which is infected with the rabies. Now this rabies, all this virus should have to go to the central nervous system for the features to appear. Now, how this rabies virus will go to the central nervous system? This rabies virus uses this dynein. Actually, I have said you here, see, dynein, it's helping in, see, it's dynein, it helps in the movement of vesicles from the nerve terminal to the cell body, So this rabies virus, it will go and sit in the vesicle. So what dynein will do? Dynein will take the vesicle which is infected with the polio virus or the rabies virus to the central nervous system. The transport will occur. The rabies virus, polio virus, and the tetanus toxin, even the tetanus toxin, all of them, they use as a dynein molecule. By using this dynein molecule, okay, their reverse axonal transport will occur, so they will reach the central nervous system. Next, tubulin. We have discussed about the dynein, kinesin, dynein. Done. Now let's talk about the tubulin molecule. Tubulin molecule, it helps in chromosomal movement. So during the mitosis, the chromosomes need to be moving towards their poles. The movement of these chromosomes will be done with the help of molecule called as a tubulin. Okay. Now, if you can inhibit this tubulin, if you can inhibit the formation of tubulin, the chromosomes are not going to move. If the chromosomes are not going to move, cell division will not occur, mitosis will not occur. So there are drugs which are called as a microtubule inhibitors, which includes vincristine, vinblastin, which are examples of vinca alkaloids, and paclitaxel, which is an example of taxanes. So why I am saying this is, these drugs can be used in the treatment of gout. These drugs can also be used in the treatment of cancers. Okay, so direct question, microtubule inhibitors include vincristine, vinblastin, paclitaxel. They inhibit the tubulin formation. Okay, tubulin formation, so that chromosomes are not going to move towards their poles. Now let's talk about intermediary filaments. Okay, intermediate filaments are the abundant filaments. Okay, abundant filaments out of all the cytoskeletal proteins, microtubules, intermediate filaments, microfilaments. The abundant proteins are the intermediate filaments. Now these intermediate filaments include keratin, desmin, vimentin, lavin. Important filaments which you should know. Now this keratin filament, one important point is keratin filament, it's present where? It's present in the epithelial cells in the form of cytokeratin. So this keratin filament can be used as a marker of, it is used as a tumor marker of squamous cell carcinomas. So squamous cell carcinomas are the carcinomas arising from the epithelial cells. So keratin or cytokeratin is a marker of keratin pearls. Okay, these terms are very important. Cytokeratin, keratin pearls, or keratin is a marker of squamous cell carcinomas. Desmin, desmin, it's present mainly in the skeletal muscles. Okay, desmin is the intermediary filament which is present in the skeletal muscles. Desmin is a marker of it's a marker for the cancer of skeletal muscles, that is rhabdomyosarcomas. So what is the marker of rhabdomyosarcoma? Rhabdomyosarcoma means cancer of skeletal muscles, right? So for the rhabdomyosarcomas, the marker is desmin. For squamous cell carcinomas, the marker is keratin. And vimentin is something present mainly in the connective tissue cells, especially the fibroblast. MCQ, especially in the fibroblast. Okay, one important point: vimentin is abundant in fibroblasts. And lamin, important point. What is the important point about the lamin? See, lamin, it is an intermediary filament present inside the nucleus. Now, whenever there is any defect in this lamin, it causes a condition called as a Werner syndrome. Okay, Werner syndrome or progeria. So, progeria or Werner syndrome is due to defective in lamin. What exactly is this progeria? Progeria means early aging. The person is going to age very quickly. A person of 15 years or 20 years will look like something like a 50 years old patient. Okay, so premature aging or early aging. Okay, premature aging. Okay, so these are the important topics which I want you to know, guys. I have discussed all the important points. Hope the class is helpful. Actually, I couldn't even read your comments because my phone got switched off. I have done the endocrine, renal, and important points from the general. Please watch both part 1 and part 2 before going to the exams. Please share it with your friends. So guys, hope the class is helpful. See you with the other classes. I will try to make many classes before your exam if possible. Hope the class is helpful. See you in our next class. Thank you.